Imagine picking up a prescription from the pharmacist.
Well, we've all been there.
Right. So you open the box, you unfold that, that densely printed information packet.
The one nobody actually reads.
Exactly. But this time you do read it, and the warning label right at the top explicitly says, "Do not apply to genital skin."
Which is just a terrifying moment for anyone reading it.
Completely terrifying, because your dermatologist just told you to apply this ultra-potent chemical to your most intimate, sensitive areas, potentially for the rest of your life.
Yeah, it feels like a massive medical contradiction.
You're essentially being asked to break the cardinal rule printed on the medication you literally just bought. And today, we're diving straight into the heart of that paradox.
Because understanding the cellular mechanics of, well, why that warning actually does not apply to this specific diagnosis, that is the key to entirely changing how you live with it.
Welcome to a brand new deep dive. We have a formidable stack of sources to parse through today for you.
We do. We're looking at comprehensive clinical guidelines from the British Association of Dermatologists.
As well as the British Society for the Study of Vulval Disease, NHS data, and some incredibly detailed clinical briefs on cutting-edge regenerative therapies.
That's a lot of ground to cover.
It is, but we are zeroing in on lichen sclerosus. And the clear mission for our analysis today is to answer one very specific, very daunting question. Does lichen sclerosus actually require lifelong treatment?
It's the question every patient wants answered.
Right. And since you're listening to this, you likely already know the intense itching, the visual changes, that cigarette paper skin texture.
And just the massive frustration that comes with LS.
Yeah, so we are skipping the basic definitions today. We need to get straight into the engine room of this disease to figure out if you really have to treat it forever.
And to answer that question of lifelong treatment, we have to look at what's fundamentally driving the destruction of the tissue.
Okay, so what is the actual driver here?
Well, lichen sclerosus is driven by a misdirected, cell-mediated autoimmune response.
Meaning the immune system is turning on itself.
Exactly. Specifically, your body's own T cells. Those are the specialized white blood cells that normally, hunt down viruses. They start targeting the basement membrane zone of your skin.
And the basement membrane is what exactly?
It's the crucial layer that basically glues the top layer of your skin, the epidermis, to the deeper dermis underneath.
Okay, so if we use, a construction analogy, you hire a crew to renovate your house, but the crew gets totally confused. So instead of fixing the roof, these T cells start aggressively dismantling the foundation and ripping up the floorboard.
That's a perfect way to look at it. They're working incredibly hard, but they are actively destroying the architecture of the tissue.
Wow.
And that rogue crew is actually highly responsive to their environment. Which brings us to a crucial biological mechanism that explains why LS behaves the way it does.
Okay, what's the mechanism?
It's called the Koebner response. This is a phenomenon where the skin develops lesions at sites of specific, often minor physical trauma or friction.
Wait, I want to pause on that because it sounds incredibly counterintuitive.
How so?
If the immune system is already attacking the skin, why would minor friction like, riding a bike or wearing tight jeans make an autoimmune response worse? It's not like friction introduces a new virus.
No, it doesn't. But it comes down to mechanotransduction.
Mechanotransduction, okay.
Yeah. When your skin experiences friction, the physical stress on those cells causes them to release stress signals, including various pro-inflammatory cytokines.
Like sending up a flare.
Exactly. In a normal body, those cytokines act like a localized flare, calling in a small immune response to just repair the micro tears from the friction. But in someone with LS, those signaling pathways are basically hijacked.
So the flare goes up, but the wrong crew answers the call.
You got it. The T cells that arrive aren't there to repair. They're the rogue cells programmed to attack that basement membrane. So the friction from horseback riding, cycling, restrictive clothing, or even the chemical irritation from wearing incontinence pads or panty liners.
It effectively summons the destructive forces right to that specific geographic location.
Yes. The everyday physical wear and tear acts as a direct accelerant to the autoimmune fire.
Which explains why active daily management is so required. I mean, you have a construction crew that never truly clocks out, and everyday activities can accidentally just hand them a megaphone.
That is the reality of it.
And that brings us directly back to the paradox we started with. The gold standard treatment, universally recommended across all our clinical sources, is a 3-month tapering regime of ultra-potent topical corticosteroids.
The most common one mentioned being clobetasol propionate.
Right. But we have that terrifying warning label, "Do not apply to genital skin." And if steroids are known to thin the skin over time, how can a doctor prescribe an ultrapotent steroid to skin that LS is already aggressively thinning out?
It sounds crazy, I know. But we have to unpack the mechanism of action of the steroid versus the mechanism of the disease.
Okay, let's break it down.
The warning label in the box is written for healthy skin. In healthy tissue, a potent steroid reduces cellular turnover, which can indeed cause the skin to atrophy or thin out over time.
But the rules of biology change when lichen sclerosus is present.
Exactly, because the LS itself is what is causing the structural thinning.
Wait, really? How does the disease do the thinning?
The LS inflammatory cascade actually paralyzes the fibroblasts.
And fibroblasts are...
They're the cells responsible for synthesizing collagen and maintaining the structural integrity of your skin.
Okay, so the inflammation just shuts them down.
Right, because the T cells are causing this chronic inflammation at the basement membrane. The fibroblasts stop producing collagen and the skin thins out. It turns incredibly fragile and crinkly.
So what exactly happens when you apply the corbetazole propionate? Like, how does it interact with those T cells and the paralyzed fibroblasts?
Well, the steroid molecules penetrate the cell membranes and bind to glucocorticoid receptors inside the cells.
Okay.
This complex then moves into the nucleus and actually alters the gene expression. It aggressively downregulates the production of those pro-inflammatory cytokines we mentioned earlier.
So it basically flips the master switch off on the T cell attack.
Yes. The site manager steps in and fires the rogue construction crew.
Ah, I love that.
And here's the crucial part that reverses the whole paradox. Once that overwhelming inflammatory environment is neutralized by the steroid, those paralyzed fibroblasts wake back up.
Oh, wow. So they start working again.
They do. They begin producing collagen again. They actively rebuild the basement membrane. So for an LS patient, the steroid does the exact opposite of what the warning label suggests.
It doesn't thin the skin.
No, it reverses the thinning caused by the disease by giving the tissue a chance to actually heal its architecture.
That honestly reframes the entire treatment. I mean, you're not putting a destructive chemical on sensitive skin. You are putting up a biochemical shield so the skin can finally breathe and rebuild itself.
Exactly. But, and this is a big but, the guidelines are incredibly strict about how to use this shield. You don't just slather it on like lotion.
Right, precision is mandatory here.
It really is. The guidelines specify using a fingertip unit, which is just the amount of ointment squeezed from the tip of an adult finger to that first crease.
And that precise amount is enough to treat the whole affected area safely.
It is. The standard protocol is to use it daily for a month, then taper down to every other day for a month, and eventually drop to a maintenance dose of just twice a week.
And alongside the steroid, every single source we have heavily emphasizes the daily use of emollients, right? Like barrier creams, Ceterbin, or Vaseline.
Yeah, emollients serve a huge dual purpose here. They are not just moisturizers.
Because of the friction thing we talked about.
Exactly. Remember the Koebner response triggered by irritation. The genital skin is constantly exposed to moisture, friction, and urine.
So a thick layer of an emollient acts as an inert physical shield.
Right. It repairs the lipid mantle of the skin, preventing those microirritants from ever reaching the cells to trigger the stress signals in the first place.
Okay, so picture this. The patient follows the rules. They use the fingertip unit, they taper the steroids down, they use their emollients perfectly.
And it works.
Right, the intense itching stops, the physical pain vanishes, the skin actually starts looking completely normal again.
It's a huge relief.
But at this exact moment, the absolute strongest human instinct is to toss that steroid tube right in the trash. I mean, you look at your skin, you feel fine, you think, I'm cured, I don't need to put these potent chemicals on my body anymore.
And that instinct, while completely rational, is exactly what allows the disease to quietly take background.
So, to definitively answer the core question of our deep dive today,
No, you cannot throw the tube away. The clinical consensus is absolute. Lichen sclerosus requires lifelong management.
wow.
Lifelong.
Yes, even when every single symptom disappears, maintaining a dose of steroids once or twice a week is non-negotiable.
You know, it really reminds me of the physics of wearing a retainer after getting your braces off.
Oh, that's a great analogy.
Right. The orthodontist takes the metal off, and your teeth look structurally perfect. They feel totally fine. But if you stop wearing that retainer at night, the underlying tension and the biological forces in your jaw will silently and slowly shift everything back.
Exactly.
You won't notice it on day one or even month one, but a year later, the architecture of your mouth has entirely relapsed.
It is the exact same dynamic with LS. The underlying autoimmune memory, those rogue T cells, it doesn't simply vanish because the inflammation is currently suppressed.
The disease is basically just dormant. Exactly. If you withdraw the maintenance steroid, the biochemical shield drops. The T cells re-infiltrate the basement membrane, and the destruction resumes. And the scary part is, it often happens without the immediate return of the itch to warn you.
Let's dig into what that silent destruction actually looks like, because if a patient thinks, well, I'll just stop the cream and if the itch comes back, I'll just start again, the sources indicate they are risking severe, irreversible consequences.
They are.
Which fundamentally changes the mechanics of the body. I mean, that makes urination difficult and sexual intimacy incredibly painful, if not completely impossible.
Absolutely. And this structural destruction happens in men as well.
Really? How does it present in men?
Untreated LS in men, which is clinically referred to as balanitis cirrhotica obliterans, it causes the foreskin to scar and tighten to the point where it simply cannot be retracted.
That sounds incredibly painful.
It is. It can also cause strictures or severe narrowing of the urethra, making passing urine an agonizing process.
That architectural damage is severe enough on its own. But the guidelines outline another, even more critical reason for lifelong maintenance, don't they?
Yes, they do. There is a documented cancer risk associated with untreated lichen sclerosus.
This is huge. Both the British Association of Dermatologists and the BSSVD guidelines are very clear on this.
They are. Patients with untreated or poorly controlled lichen sclerosus have a 3 to 5% lifetime risk of developing squamous cell carcinoma, which is a type of skin cancer on the affected genital or anal areas.
I want to understand the exact link there, though, because, how does an autoimmune skin condition suddenly turn into a squamous cell carcinoma? What is the bridge between those two things?
The bridge is chronic, unmitigated inflammation.
Okay, so how does inflammation cause cancer?
Well, when tissues are in a constant state of inflammation and repair, the immune cells release these things called reactive oxygen species.
Reactive oxygen species.
Right. And over years, these highly reactive molecules can cause direct DNA damage to the surrounding skin cells. Specifically, they can cause mutations in tumor suppressor genes, like the p53 gene.
And the p53 gene normally stops cancer cells from growing, right?
You got it. So when the skin is trapped in this endless cycle of destruction and rapid flawed repair, the chance of a cellular copying error, a malignant mutation, just skyrockets.
So the maintenance dose of the steroid isn't just about keeping the skin comfortable. It's an active, targeted intervention to stop the release of those reactive oxygen species.
Precisely. Regular steroid maintenance actively suppresses the chronic inflammation, which prevents the DNA damage that leads to cellular mutation.
So applying that small amount of ointment twice a week is quite literally an active cancer prevention strategy.
It absolutely is.
Wow. When you lay out the biological reality, the threat of irreversible scarring, the loss of anatomy, the 3 to 5% cancer risk, the necessity of lifelong treatment makes complete sense.
It does.
But, from a patient's perspective, staring down a lifetime of applying potent steroids to your most intimate areas is exhausting. Steroid fatigue is incredibly real.
It is. And that desperation for an exit strategy is exactly why we're seeing an explosion of clinics offering highly advanced regenerative therapies.
Yeah, the regenerative medicine landscape is moving incredibly fast right now, and clinics are aggressively marketing these treatments to LS patients.
We're looking at therapies like fractional CO2 lasers, platelet-rich plasma or PRP, and adipose-derived stem cell injections.
And I see undeniable clinical data in these briefs showing real symptom relief from these high-tech therapies. Patients report better skin texture, improved elasticity, and a major reduction in pain.
The symptom relief is definitely documented.
But I have to push back a bit on how these are being framed as cures. If a treatment like PRP works by delivering concentrated growth factors to heal the damaged tissue, how does that actually solve the underlying misdirected immune response?
That's the million-dollar question.
Aren't we just building a brand new, highly expensive house for the rogue construction crew to immediately tear down again?
That is the crucial distinction that separates a treatment from an actual cure. Let's look at the cellular biology of how they work to understand their limitations.
Okay, let's start with PRP.
With platelet-rich plasma, blood is drawn and spun in a centrifuge to isolate the platelets. These platelets are packed with alpha granules that release massive amounts of vascular endothelial growth factor, or VEGF, and transforming growth factor beta.
And what do those do?
When injected into the LS lesions, this triggers aggressive angiogenesis, which is the formation of new blood vessels, and it stimulates those lazy fibroblasts to pump out fresh collagen.
Okay, and what about the fractional CO2 lasers? They seem to be everywhere right now.
The laser works by creating thousands of,
But
but none of them reset the systemic immune memory stored in your lymph nodes. They do not eliminate the rogue T cells that are programmed to attack the basement membrane.
so the original blueprint is still flawed.
Exactly. This is why every major clinical guideline emphasizes that these regenerative options are purely adjunctive or second-line therapies.
So they are extras.
Right. They are fantastic tools to add to the toolkit, particularly for patients dealing with stubborn scar tissue or severe atrophy that steroids alone just cannot reverse. But they do not replace the clobetasol propionate.
Because the T cells are still there.
Yes, if you spend thousands of dollars on PRP or stem cells and then stop your maintenance steroids, those T cells will simply return and destroy the newly regenerated collagen.
You cannot laser your way out of an autoimmune disease. The biochemical shield still has to be maintained. Which brings up another mechanical intervention, surgery.
Ah, yes.
I initially assumed surgery could be a permanent fix for the severe architectural damage. Like, if there's a rigid scar narrowing the vaginal entrance, or a severely scarred foreskin, why not just have a surgeon excise the damaged tissue, open things up, and start over?
Well, surgery is sometimes absolutely necessary to restore function. Surgeons can perform procedures like a perineotomy to widen a narrowed introitus or a circumcision to remove a severely strictured foreskin. But if we go back to the mechanics we discussed at the very beginning, the Koebner response surgery is essentially massive, localized trauma.
Oh, wow. Wait, so the incision itself acts as the ultimate friction trigger.
Exactly. The surgical incision releases a massive wave of pro-inflammatory cytokines, frantically calling the immune system to repair the cut.
And the wrong crew answers the call.
Yes. If the patient is not aggressively using their topical steroids before and after that surgery, the rogue T cells flood the surgical site. The disease will immediately attack the new surgical scars, often resulting in scarring and fusion that is worse than the original problem.
So, all roads, whether it's high-tech laser therapy, stem cell injections, or corrective surgery, inevitably lead right back to the maintenance routine.
The maintenance routine is the anchor. You can rebuild the house using the most advanced techniques in the world, but you still have to keep the site manager on duty to stop the rogue crew from coming back.
Let's pull all of this together. We started with a very clear mission today. Does lichen sclerosus require lifelong treatment?
And the clinical consensus, driven by the underlying biology of the disease, is an undeniable yes.
You have to keep applying the treatment even when you feel perfectly fine.
Right. But looking at the exact mechanisms, how clobetasol propionate shuts down the cytokines, how it wakes up the fibroblasts, and how it actively blocks the DNA damage that leads to cancer, it completely changes the narrative.
It does. Lifelong treatment does not have to mean a life-limiting condition.
It's a shift from feeling controlled by the disease to actively controlling it.
Exactly. You are holding a paradox in a little metal tube. The box says, do not use on genitals. But the science proves that this specific medication is the exact key to saving that tissue.
It really is the ultimate biochemical shield.
With a tiny amount of weekly maintenance, just a fingertip unit of ointment, and a consistent layer of a simple emollient, you have the power to halt the architectural destruction. You can reverse the thinning. You can prevent the irreversible scarring.
And most importantly, you actively lower your risk of cellular mutation.
Yes. For you listening, whether you are managing this diagnosis yourself or supporting a partner through it, understanding the biological why behind that maintenance dose is your ultimate medical shortcut to peace of mind.
When you fully grasp the mechanics, the treatment stops being a burden and becomes a powerful protective shield. But, looking ahead, there is a fascinating, highly provocative question hovering over the future of this field.
Oh, what's that?
Well, we discussed how mesenchymal stem cells secrete exosomes that can modulate the localized immune response and temporarily calm the inflammation.
Right, they change the local environment even if they don't wipe out the systemic T-cell memory.
Currently, yes. But immunology is advancing incredibly rapidly. If we can already harness stem cells to calm the local environment and rebuild tissue, the next frontier isn't just about suppressing the rogue T cells with steroids.
Okay, so what is it?
The question becomes, could we eventually engineer these cellular therapies to fundamentally reprogram the immune memory? What if, in the next decade, a targeted biologic or an advanced stem cell treatment doesn't just build a new house, but actually retrains the T cells to read the right blueprints again?
Wow. Taking the misdirected crew and turning them back into the repairmen they were always supposed to be, That is an incredibly hopeful horizon to look toward.
It really is.
But until that science arrives, keep your site manager on duty. Keep your biochemical shield up. Don't let the paradox of the warning label scare you away from protecting your architecture, and keep up with that maintenance routine.